Next, I'll invite Professor Sushmita Kaushik. She is a professor at PGI Chandigarh, and she is very well-known glaucoma faculty, and she has special interest in congenital glaucoma. But today she'll be talking about the SLT in management of glaucoma, and I think she will consider more on the light study. Please, Dr. Sushmita.
Yeah, thank you. Thank you for the opportunity to bring this. And so I'd be talking about an important study, the LIGHT study published not so long ago. So we know that primary open-angle glaucoma is irreversible, and intraocular pressure is the only modifying risk factor. So we do have hypotensive drugs to reduce the pressure, and we also have the SLT, which has been around for a long time. It's laser application to the dysfunctional trabecular meshwork. Coming to the LIGHT study, now this was a multi-center randomized controlled trial with 6 participating centers which studied patients between October 2012 and 2014. The research question, in a nutshell, was which is better as a first-line medication for ocular hypertension and moderate primary open-angle glaucoma, SLT versus medication, and they decided to look at clinical efficacy and the cost effectiveness. So these were the 2 papers that came out of that study. While reading, and this is a bit of a caveat, I just want you to look at fine print when you read, because if you notice, the principal investigator, Gus Gazzard, is a financial recipient from both Lumenis and LX, and both Lumenis and LX are manufacturers of the SLT. So that's something to keep in mind as you go along and you read the study. Well, so the inclusion criteria was newly diagnosed and untreated POAG, OHT, including pseudoexfoliation, and a decision to treat was made by the consulting ophthalmologist. They were all adult patients able to provide consent. They excluded advanced POAG, which means a mean deviation worse than -12, visual acuity less than 636, all secondary glaucomas, any previous treatments, any cataracts, and any previous surgeries. So the baseline had a comprehensive evaluation, visual field optic disc, CCT. This is routine, but what was added was a lot of questionnaires for quality of life and cost effectiveness of glaucoma care. So the group allocation was of consecutive eligible patients were randomized in a 1:1 ratio to receive either medical therapy, which was the standard, or SLT, and they were monitored for 3 years. So the monitoring intervals and treatment decisions were guided by the central clinical decision support software. The first trial arm 1 was the laser pathway. The SLT had standard protocols for all patients, 360 degrees treated, 100 overlapping spots with 25 per quadrant, and laser energy varying between 0.3 to 1.4 millijoules, depending upon the appearance of the champagne bubbles. The clinical endpoint were these bubble formation at the trabecular meshwork for at least 50% of the time. At least half the times you should have seen the bubbles. 1 treatment was allowed. So remember that 1 SLT failure was not considered failure. 1 retreatment was allowed provided there was an initial response. If there was no initial response, it was taken as a failure. But if there was a response which waned over time, within those 3 years, 1 retreatment was allowed. And after 2 SLT treatments, if the IOP had to be even lower, then medical management was the escalation. Whereas in trial arm 2, which was the standard of care, the first line was prostaglandin analogs and the second was a beta blocker. The third or fourth line was a carbonic anhydrase inhibitor or alpha agonist, as the case would be. A maximal medical therapy was defined as the most intensive combination of drops an individual could reasonably, reliably, and safely use, but also meant a maximum of 3 drugs and 5 doses a day. So if they had to put it more than 5 times a day, it was not allowed. The primary outcome measures. Now they set out to study clinical efficacy, and yet a primary outcome measure was not intraocular pressure reduction. It was health-related quality of life and quality-adjusted life years, baseline and 6 monthly in the 3 years. The secondary outcome measure was, again, cost effectiveness. The cost cumulative calculated for an SLT versus medical management. The objective measurement, which was right at the bottom, was what troubles all of us, the IOP lowering and visual function preservation. So interestingly, in this study, the IOP lowering and preservation of vision was right at the bottom of everything else. So here are the results. Out of 718 randomized patients, 356 were allocated to SLT and 362 allocated to medical, out of which 329 and 323 respectively were analyzed. So baseline, because they were randomized, they were much similar, and as you can see, the diagnosis was primarily open-angle glaucoma and ocular hypertension. The baseline characteristics was also similar. I've highlighted the intraocular pressure was about 24 in both, and the CCT was also similar. Why they did the CCT and measured in both was because they included ocular hypertension. So this was the baseline questionnaire score, which I've just listed, and that's how the results were. Now, coming to at 36 months, there was no difference in the quality of life between both of them. So that was interesting. There was no significant difference found as per the questionnaire as to quality of life. And here you are, it's depicted in graphs also. The quality of life graphs were similar 6 monthly over 3 years. What was different was that in the SLT group, 78% were without medications at the end of 3 years, whereas only 16 were without medication, which to me didn't make sense because they were on medical treatment, but this is what the article says, so I've put it in. So obviously, 64 plus 18, about 80% were on 1 or 2 drops, which is to be expected, but the main thing was that those who underwent SLT, 3/4 of them did not require drops. The other thing is that if you see from the other, now it's a very busy chart, but if you can see that 3.8% of SLT versus 5.8% on medical groups progressed, which wasn't statistically significant. And in the visual field progression, again, if you see the numbers, far more progressed in the medical treatment group rather than the SLT. Now, whether or not that's been discussed, it translates into a better dampening of fluctuation remains to be seen, but this is what they found. And the ocular surgeries required were all in the medical group, very, very few in the SLT group. Only phacoemulsification, nobody required a trabeculectomy, whereas 11 in the medical group required a trabeculectomy. So I've just highlighted the salient differences which they found at the end of 3 years. And there was no difference in the clinical endpoints regarding visual acuity, intraocular pressure, or visual field. So the things that as a clinician concern us usually had no difference in either of the groups. There were no sight-threatening complications of SLT, and in 6 eyes of 6 patients, intraocular pressure rose on the day of treatment by more than 5 millimeters, but only 1 required treatment. They were more self-limiting. Ophthalmic drop-related adverse effects were only seen, obviously, in the eye drops group, and 34% in the SLT group reported a transient discomfort with blurred vision, photophobia, and even hyperemia. Regarding the cost of treatment, at 3 years, a cumulative cost was calculated to be £200 in the SLT and £465 in the medical group. So that was significantly almost double. So to summarize, there were no significant differences in the health-related quality of life or clinical outcomes. They were the same. However, the lower cost in SLT compared with the conventional treatment pathway, and what is important is 74% of patients in the laser group remained drop-free for 3 years. So it may provide better diurnal pressure control or stability and continue because of the continuous effect of the trabecular meshwork, whereas the drops would be sporadic as and when you put them in, and episodic in their control. And there is a lower rate of cataract surgery in the SLT group, possibly also as a result of the medications. I acknowledge my senior resident, Dr. Gaurav, who provided me with some data. Thank you.
Yeah, thanks, Dr. Sushmita, for a nice talk. We'll take the questions at the end. And I'll invite Ms. Regina. She'll be talking about the introduction. Any question for Dr. Sushmita? She has some other presentation.
Rajun, just one question for Dr. Sushmita.
Yeah, please.
So, is SLT covered in under insurance in India?
I think it depends on the policy. I don't think there's a
that is going to
blanket, yeah.
Help the compliance and avoid the cost effectiveness of the medicine.
True, but the cost effectiveness is also in terms of not requiring repeated medication and just being the cost of the treatment, even if it is whether or not covered by insurance. So even if it's not covered by insurance, it's going to be a one-time cost of whatever your treatment cost is.
But is any company giving insurance coverage for the SLT
So,
procedure?
Dr. Mazhar, it all depends upon the different insurance company.
Yeah,
So some of the insurance companies do reimburse
Laser.
SLT, some don't. So that all is individualized, because I have quite a few patients who have been reimbursed by encephalitis and some are not reimbursed. So I think that all depends upon individual company.
Most of the companies, they don't reimburse daycare procedures. This is OPD procedure.
okay. So you can admit them and do your SLT. They'll get reimbursed.